All right, let's begin. So welcome to today's webinar with CureDuchenne. This webinar is titled The Benefits of Corticosteroids Along the Duchenne Journey. I'll be hosting today. My name is Carrie Johnson. I am the Director of Community Engagement here at CureDuchenne, and we have some contact information on the screen. So cares@cureduchenne.org is going to be a great way to reach us if you have any questions regarding this webinar, what you heard today, or just CureDuchenne and our programs in general. We encourage you to reach out. So some housekeeping for today. I know we are all probably very comfortable with how webinars work now, but just so you know, this webinar is being recorded and it will be added to our online index of resources called the CureDuchenne Resource Library soon. You can find that on cureduchenne.org. The chat feature is turned on today, so you'll be able to discuss things with us, with other attendees on today's webinar, and share your story. We leave that open so you can kind of impart your journey on the rest of the people on the webinar. The Q&A is also open today, so you will be able to ask questions of our speakers. They must be relevant, webinar appropriate, and general in nature. If you do have very specific questions about your child or an individual with Duchenne, please do reach out to cares@cureduchenne.org, and I'm very, very happy to link you to an expert where we can have a more personal conversation. And if we don't answer your question live, we will get in touch with you after the webinar. Sometimes we can't get through them all in an hour. So I just wanted to highlight today, before we get started, a few of CureDuchenne's programs. I put the QR code up here, so you're welcome to put your phone up and scan it, and it'll lead you to a web page that has kind of an index of our collective resources, which are wonderful. But I did want to highlight this year we have gone back in person on a limited basis. CureDuchenne will be hosting workshops and dinner sessions in cities around the United States, as well as, of course, our CureDuchenne Futures Conference coming up in May in Orlando. In addition to that, we are still doing virtual things. So if you can't make it or we're not in your city, we are having educational webinars like today's. We also have fun coffee and cocktail talks, which are social events for the community. So the virtual option is very much still a thing at CureDuchenne. And a few other highlights would be our CureDuchenne one-to-one program, where we link you with an expert, maybe they're an expert PT or our chief scientific advisor, to talk one-on-one about your family and the specifics of your individual with Duchenne and what you would like to talk about, whether that's trials, treatments, routines, etc. And we have many, many more programs. So I do welcome you to scan that QR code and join the CureDuchenne family. We love to get in touch, and I love to hear from families. So I'll be the one answering the phone. Please call. As I mentioned before, I cannot believe this is 1 month away, but we will be in Orlando at the end of May at our Futures Conference. There is still absolutely time to sign up. So it is a hybrid event, which means we have a virtual aspect to it, but we would love to see you in person. We have travel grants available. We've put together a wonderful list of tips and tricks for families to travel to the conference. So we're here to support you if you would like to come see us in person, and I absolutely can't wait. We're focusing on building community, which I think is a perfect theme for this year. Okay, let's get to today's agenda. We're going to be talking about the benefits of corticosteroids along the Duchenne journey, and we have Dr. Panda, as a lot of you affectionately call him. He's a pediatric neurologist from Arkansas Children's. And then we have one of our own wonderful families that are going to share a little bit about their journey with steroids and answer some questions on the family unit side of things. So that is Sheryl Marrazzo, and also Jake Marrazzo is able to join us today. So I'm thrilled to have all three of them on board for today's webinar. All right, Dr. Panda, I'm going to welcome you onto the webinar. So please go ahead and just tell our attendees a little bit about yourself, and I'll hand off the remote to you.
Awesome. Thank you, Carrie.
Yeah.
Hello, everyone. Thanks. Thanks for joining, and thank you, CureDuchenne, for this opportunity. I'm excited to talk about steroids to our families. So as you guys saw, my name is really long. It's Veerapandiyan, but I go by Panda. And I'm a pediatric neurologist and neuromuscular specialist at Arkansas Children's Hospital. So we do have quite a large neuromuscular program where we follow kids and families with Duchenne, Becker, other types of dystrophinopathy carriers. And we do have a multidisciplinary setup of other specialists like cardiology, pulmonology, nutrition, and psychology, and other specialists that we need. So we're going to talk about, I'm not going to dive into a lot of science, but just kind of briefly touch upon a few things that we need to know about the corticosteroids along the Duchenne journey. All right, so these are my disclosures. All right, so before we jump onto the main content, we all know about the Duchenne. We all know the natural history of Duchenne, and we do know corticosteroids work. I'm not going to get into details of their natural history, but the needs for these boys and kids, the challenges that they face really differ at different stages of the disease, different stages of Duchenne. So as you all probably know, when they present to us, they usually present with what we call delays in their development. They have motor delays. They have problems walking, jumping, getting up from the floor. And this could start as early as 2 to 3 years, but sometimes some kids can have what we call more of behavioral problems, anxiety, even before their motor problems show up. And so as time passes on, then they go to this next stage, right? Where you start to notice some difficulties, again, climbing stairs, difficulties walking, getting up from the chair, and we call it ambulatory phase. Or so in those periods, corticosteroids can preserve motor function and delay the progression of the disease. As time goes on, then they kind of get into the next phase where they lose the ability to walk, and they get onto the wheelchair. In those phases, their needs, the focus changes. Right now, at this point, we want to preserve that hand function, so which is helpful for them to maintain their daily activities, like feeding themselves, driving their wheelchair, their heart function, which is more important, and their respiratory function. So corticosteroids can delay decline in these functions, and we'll touch upon that in a few minutes. So like I said, just to emphasize, the challenges and the needs for these boys differ at different stages of life, at different stages of disease, and corticosteroids may help in each different stages. All right. Okay, so why, as we all know, this is corticosteroids are the standard of care for Duchenne, right? So why corticosteroids? So we have a lot of studies, research, clinical trials that I've done in the past that have demonstrated that they are beneficial in the treatment of Duchenne muscular dystrophy. So there are long-term effects and short-term effects, right? So we know it improves their muscle strength and function. It improves their the breathing function. It actually delays the loss of ambulation. It actually prolongs the ambulation by 2 to 5 years. Steroids reduces the need for scoliosis surgery. It actually delays the onset of cardiomyopathy, meaning the cardiac function is preserved longer. And it actually increases the survival of these boys. So that's why the standard of care is starting them on corticosteroids. Now, the question comes, when do we start them on steroids? Sorry. So as the standard of care guidelines, recommendations, however you call it, is that you discuss the steroids near the time of diagnosis. It's really hard decision for families to make, because there's a lot of information you need to know about steroids, the benefits, the risks, and then we have to make this decision. So the recommendation is to discuss at the time of diagnosis. And we usually like to start them before they reaches a plateau phase, meaning before they start to lose any strength or before they start to show any sort of signs or symptoms, typically around age 4 to 5 years. Now, the practice actually varies. Now we have more data and more information that we have learned from our research that we could start this as early as age 2. So the practice of starting steroids among the neuromuscular neurologists and families, it actually varies quite a bit. Personally, I usually start them as early as 2.5 years of age. And as you know, Emflaza is actually approved by FDA for 2 years and older with Duchenne muscular dystrophy. Then we're going to talk about the dosing. All right, this is again just this flow chart is from the publication that talks about the care guidelines. So when to start steroids, how to discuss, what's the so what are the things that you want to know about before you begin steroids, and the emphasis on the nutrition consultation, because as we all know, steroids can increase your appetite, it can cause weight gain. So we want to get good idea about the good nutrition that these kids need, so we could prevent that aspect of it. We'll talk about the alternate regimens, dosing changes, and stuff in a bit. All right, so what dosing? The current recommended dosing that we all use is the prednisone doses up there, deflazacort or Emflaza, that's 0.9 milligram per kilogram per day. But these are recommendations, right? So you could, based on your kid's individual experience, these dosing can be, the daily dosing can be modified depending on their, how well they respond to it, and also there's any side effects, and work around that to come up with the dose that actually works better for your son. What are the, there are alternate regimens that people use. In the US, if you probably heard about the weekend high dose regimens, like people, so you don't take steroids during the weekday, and the 2 weekends you take high dose steroids for 2 days, just Saturday and Sunday, whatever, 2 days in a week. Some of the other countries, they go what's called 10 days off regimen as well. What is the maximum dose that we could use in a day? Usually, even though we have the milligram per kilogram, so 0.75 milligram per kilogram of the body weight, the maximum dose that we tend not to go above for prednisone is 36 milligrams per day, and for deflazacort is 40 milligrams per day. And then I put the general dose that we use on the weekend high dose regimen. Again, there is no, I don't think we have a lot of research about what's a good dose. This is just a general practice that we follow. Right, I'm not going to dive into a lot of this clinical data, but I think it is important to know. So this was from a study that was done a long time ago based in University of Rochester, New York, where they compared deflazacort, which is Emflaza, or prednisone, and placebo, meaning no steroids, and kids with Duchenne muscular dystrophy. As you could see here, the light blue color is deflazacort 0.9 milligram per kilogram dose, and this is deflazacort 1.2, slightly higher dose than 0.9, and this is your prednisone, and this is placebo, who these kids were not taking any steroids. And this is, they looked at the motor strength or muscle strength from baseline to week 12. As you could see, the placebo group, it went down, whereas the steroids group, it's actually, there's improvement in the muscle strength that was noted from baseline to week 12. Now, the same group, when they looked at from week 12 to week 52, they found this result. Like, this is a placebo group, as you could see. The strength was going down, right? When they looked at the prednisone and the deflazacort Emflaza group, actually the muscle strength improved from week 12 to week 52 in the group that was taking Emflaza deflazacort, whereas the prednisone group, it remained kind of stable, and even there's a decline. So I think it is important that long-term follow-up is is critical to actually know about what is these steroids are doing over a long period of time. And it's the same group that looked at it. They also looked at the change in weight in these boys when they were taking steroids, right? As we know, here placebo group, the increase in the weight gain from baseline to week 12 was not that much compared to people who were taking steroids are all gaining weight. And again, we know that, right? So prednisone, people who are taking prednisone have increased risk of they have gained more weight compared to those who are taking Emflaza or deflazacort. So same kind of the results were same when they looked at from week 12 to week 52, and also from baseline to week 52. The weight gain was more in the prednisone group. All right, this is another study that actually it's called Synergy. I'm sure people have heard this name, and they had over 440 patients of Duchenne aged 22 to 28 years, and they were followed up for up to 10 years, and they found that they compared deflazacort versus prednisone, and they found that deflazacort had statistically significant preservation of key functions, motor function, like there is a 2.1-year delay in age at loss of ability to stand from supine, meaning standing from laying position. Deflazacort has kids who are on deflazacort, they lost that ability later than who were on prednisone. And same thing here, the walking ability. The kids who are on deflazacort, they were walking 2.7 years longer than the ones who are on prednisone. And similar, the ability to use your hand to mouth function. This is also another group of patients that were looked at Cincinnati Children's Hospital by Dr. Brenda Wong. Again, they looked at difference between deflazacort and prednisone, and they found deflazacort kids who were on deflazacort did better in a lot of different areas, including their motor functions and their cardiopulmonary, their breathing and cardiac function. And one of the key things that you want to note here is their the FVC predicted, which is your breathing function, was better with the deflazacort group. It's the same from Cincinnati Children's, from Dr. Brenda Wong's group. When they looked at these kids who are taking prednisone and deflazacort, the kids who are taking deflazacort, the patients who are taking deflazacort, developed scoliosis at significantly older ages than prednisone, meaning there's delay in the onset of scoliosis or spinal curvature in those boys who are taking deflazacort. All right, we kind of talked about prednisone versus deflazacort and oral corticosteroids and no corticosteroids. Right, we know corticosteroids are beneficial. Now, there's a lot of people, like we talked about the alternate regimens, right? So the high dose weekend regimens, meaning use high dose on the weekends, and then there's also the 10 days on and 10 days off regimen. And this study was just recently published, and in this study they looked at kids with Duchenne muscular dystrophy who were taking daily prednisone. There's a group of kids that were taking daily deflazacort. And then there's a group of kids who are taking alternating 10 days on and 10 days off prednisone. And then they looked at what they call composite, meaning a combination of 3 different aspects. One is the motor functioning. The second one is the pulmonary breathing function. And then they also looked at the satisfaction with treatment that were reported by the families. When they used this composite, when they combined all 3 of them, they found, again, kids who are on daily corticosteroids did much better compared to the ones who are on 10 days on and 10 days off. So again, their findings supported, again, daily corticosteroid regimen may be better than intermittent dosing regimen. But again, it's all individualized based on every single boy's need, their response, their the side effects that they'll experience. And that's conversation that needs to happen with your neurologist or neuromuscular doctor, whoever is managing you, to decide what's the best dosing. All right, so that brings us to the topic of corticosteroids after a loss of ambulation, meaning, is it helpful to continue the steroids given all the side effects that the steroids have, especially taking them for a long time? Is it worth continuing these steroids after kids stop walking? It's a difficult question, right? Because we don't have a lot of good research studies or clinical trials that would give us an answer. But from what we know so far, right, I want to highlight these two studies. That one is called PRO-DMD. Again, they looked at kids, they looked at boys with Duchenne who are non-ambulatory. They found steroid use was associated with decline, meaning delaying the decline in their breathing, heart, and also the upper limb function compared with no steroid use. Then this part right here, this is another group, MD StarNet. This was also recently published, and they looked at the boys that are non-ambulatory, that are not walking, and again, corticosteroids actually delayed their decline in their breathing function as well. There are a few other studies that were done looking at corticosteroids after these boys stopped walking. So these, again, I want to highlight these two studies as well. And this first one, they looked at boys that are 9.5 to 31 years of age, and patients who were treated with corticosteroids. They showed higher, this is FVC, again, person predicted FVC, which is one of the measures of your lung function, or breathing function, than the ones who are not receiving corticosteroids. And again, same consistent result here, that the boys who are non-ambulatory who are on corticosteroids showed improved breathing function as well. As far as the cardiac, how does it work? Does it affect the cardiac function? From PRO-DMD, yes, there is a delay in cardiac decline or cardiac function decline, but other than that, there's not a lot of information available for us to guide our decision. So as far as, again, going back to this question, should I continue the steroids after my son, or after the boy stop walking? This decision is complicated, and it has to be, again, has to be individualized. For one, it has to be individualized based on your, again, your response. How is your lung function? How is your heart function? Now, we need more, of course, we need more research studies or more data to make an informed decision about it. But based on what we know, again, like I said, so we need more studies, but until this question is unequivocally answered, based on what we know, I think we should continue corticosteroids beyond loss of ambulation. Based on what we know, again, they can delay the decline in the cardiac function, breathing function, and also the upper limb function. And like I said before, it is important to balance these benefits of the side effects of the long-term corticosteroids. And it is individualized, that it varies from one person to other person, and your family, along with your doctors, make that decision that is good for the kids. All right, so side effects. Again, I'm not going to get into a lot of details about the side effects, because we all know, right? How can we know these steroids are beneficial, right? But how can we mitigate or manage these side effects? Of course, from just looking at the steroid perspective, changing the type of steroid, right? So if someone is on prednisone, if they are experiencing side effects, of course, switch them to we can try switching them to Emflaza or Deflazacort. As you know, weight gain, behavioral side effects they are lesser in Emflaza compared to prednisone. But on the other hand, cataracts is one that kids who are on Deflazacort increase risk of developing cataracts compared to prednisone. And the another thing that you could do is reduce dosing. I mean, yes, there's dosing recommendation of 0.75 or 0.9, but maybe reduce the dosing and see if that would work, right? Then, of course, you can still consider alternate dosing, even though we know your daily dosing is better than alternate dosing, meaning high weekend dosing or 10 days on, 10 days off. Something is better than nothing, right? So maybe that's the consideration. Then we do have, long-term side effects, thinking about long-term adverse effects, if their bone health, if they have what we call osteoporosis. There are medicines that you could use to mitigate that. For obesity, if they're gaining weight, then diet, nutrition, that's important, and there are ways to manage those side effects. Again, behavioral side effects, those are from my experience. I'm sure Jake and Sheryl can talk, and you guys have experience too. Those behavioral problems are short term. They usually as they develop, as they get older, as they mature, those things go away. Those are temporary. And as a family, along with your support from the neuromuscular providers from your centers with social workers, psychology, I think we are able to manage those side effects, given that what we know how beneficial these steroids can be. I'm just going to briefly touch upon this. This is another study where they looked at when they looked at people switching from prednisone or boys switching from prednisone to Deflazacort. When they asked about looked at the key reasons for switching, the two main reasons. One of them is desire to slow disease progression. They think Deflazacort may slow the disease progression better than prednisone, and the other one is the tolerability issues, meaning side effects. So those are the two key reasons for switching. And then what they did was 6 months after switching, they looked at how effective the switching was rated, and it was rated as where 97% of them rated the switch as somewhat effective or very effective in addressing the reasons for switching. So which is important. And of course, as we know, the side effects were lower in a group that were taking prednisone compared to, were lower when they were taking Deflazacort compared to prednisone. And with that, again, going back to steroids, we talked about how important they are, different regimens, and how to manage the side effects. And I'm not going to go through this detail again. And we all should be aware of the stress dosing, meaning when kids get sick, how to adjust the steroid dose. And again, you should have that information from your center or from your provider. And also thinking about stopping the steroids, we shouldn't be stopping them abruptly. So again, we should all know about how to stop, how to wean the steroids off when we decide to stop them. And this needs to be discussed with, again, your center and your provider also. And with that, I think I'm happy to take any questions right now, or if you want to wait till the end for the discussion, that's totally fine. And thank you for your attention.
Thank you so much. That was a really insightful presentation, and we do have some questions. Before we get to those questions, though, I wanted to kind of point to your last slide where you reminded everyone just be diligent about, of course, there's stress dosing. We don't stop steroids abruptly, and there are protocols involved. CureDuchenne, just shameless plug, we have a program that has our medical ID bracelets. They're free for individuals with Duchenne and their families on the website. And they come with a little QR code Your kiddos can wear them when they go on vacation, when they go to school, when they're away from you, to give you peace of mind. It's preloaded with all of that information. So if there's an emergency physician, say, working on your child, they will see this alert bracelet and say, okay, well, there's a different steroid protocol here for this child. I just wanted to kind of plug that in as we talked about those protocols. But okay, Dr. Pena, I'm just going to go ahead and go through a few questions with you, if you don't mind.
Sure. Yeah.
All right, great.
I'm happy to read them also. I think it's from the chat.
Oh, sure. Okay, you can see them on your end. Great.
Go ahead. Yeah, go ahead. I'll let you moderate that.
Sure. So there's one kind of specific, I won't go into the specifics of it, but is there any proof, or have you seen anyone where deflazacort increases urination? And is that a side effect, or is that something dangerous that the family should take note of?
So that's an interesting question. I saw that. I personally haven't had that experience, increasing urine output with either one of the steroids. But if that's something that's ongoing, I think we need to make sure that we're not having any other bladder issues or infection and that kind of stuff.
Okay, thank you. Is there a study or a collection of studies that clearly demonstrates improved cardiac function with corticosteroid use?
Right. So I think that's one of the in my presentation I put in this I think it was pro-DMD study. That was one that they looked at a collection of patients that showed some improvement in the cardiac function after I assume this is after the after loss of ambulation. The question, right?
I think so. Maybe we can get a clarifying in there, Mindy. But
Mindy.
Yeah.
But that's one thing I guess I was mentioning before. There's not a lot of studies that actually clearly looked at cardiac function after loss of ambulation, and that's probably the one that I'm thinking of right now that actually showed improved cardiac function after loss of.
That was the pro-DMD
study. Yeah.
Okay. Thank you. And then we have one that is, what is your feeling about daily dosing versus intermittent weekend or other dosing? And I think I did see, when you were talking about side effects a little bit, you said one of the mitigating strategies was changing the dose. I'm wondering, in your experience, or if there's any studies that show, hey, this side effect is correlated with daily, and here's how we pull back on that by changing to intermittent.
Right. So there are studies that have shown, at least one or two that have shown less side effects with intermittent dosing, but it's also your efficacy is also on the lower side compared to your daily dosing. Now, I'm always again, this is still, nobody likes steroids, right? We all dream for a day for these boys with no steroids, they still get better, right? But we got to work with what we have, right? And I'm always going for daily dosing because we know, I think that's efficacious. That's better compared to any sort of intermittent dosing. But if it comes to a point that they are having adverse effects that's not manageable, there's a lot of factors. When I say not manageable, it's not just adverse effects. How the family can cope up with that, or what is the side effect? What are the other other factors that contribute to that? Then I'm compromising myself to help this kid to make this decision of switching to weekend dosing. I typically don't do 10 days on, 10 days off dosing. And you can also, I have few non-ambulatory boys who are on actually low dose compared to whatever their regular dose is, but daily dose, but on the lower end. We just have to work with the family and the boy to come up with this dose that would work for them. Again, I do know some colleagues, some of my friends who does for younger kids. If they're starting 2 or 3 years old, they just start off with intermittent dosing.
And how long would you say give that change in dose to clear up the side effect? Would that look like 6 months? Would that look like a year?
So you mean when after you switch the dose?
After you switch, how long is sort of the grace period?
it really depends on what side effect you're talking about. If it is weight gain, you may want to wait a little longer. If it is more of behavior changes, then I wouldn't wait 3 months or 4 months. I'm looking at within a month period if I'm noticing any difference.
Okay, thank you. What benefit do you find in starting patients on steroids earlier, 2 to 3 years old, as you mentioned?
Right. Again, it goes back to the efficacy. The sooner, I don't want to say the sooner you start, but there is no long-term data again based on is it going to be more beneficial than starting at age 4 or 5. But I do think it is important to delay the progression of the disease. And if I'm starting earlier, the body get used to steroids. So I'm noticing some of the side effects is not as bad, at least the short term, the immediate adverse effects that you're seeing. And I do have boys that present as early as 2 and 3 years with some manifestation of dystrophinopathy. It doesn't have to be a muscle weakness, right? They may have, their anxiety or autism spectrum-like problems. Those are due to dystrophin abnormality in the brain, right? And I think starting earlier can delay, can help with delaying the progression.
Thank you. We already answered this one. I think we can answer this one hopefully in a more general sense, Dr. Penda.
Sure.
Their son was on weekend dosing of deflazacort for 3 years, but they had to switch to daily for inclusion in a clinical trial, which I bet is on a lot of families' minds, the trial aspect of this. And she said it was catastrophic for her son, but no one recommended the weekend doses of Emflaza instead of prednisone. Do you know why that is?
But I think, again, I'm talking from, I think it's because there's just a lot of people, not a lot of people don't use it just because they haven't experienced that weekend dosing Emflaza. I use it all the time. If a kid is on Emflaza, if we need to do weekend dosing of Emflaza, we do that. We just don't have a lot of data on it, and there's not a lot of I think experience with Emflaza using weekend dose of Emflaza. I think that was probably the hesitancy to do that. I don't know how long ago was that, but now I think I see it more commonly used, and we use it all the time.
Okay. So I guess it would just be, you need to be communicating with your physician as well as the PI of the trial to figure out if there's any flexibility there, but sometimes there's not going to be, right?
Right. For the trials, it's going to be a whole different story, right? They may not allow you to be on the trial. If you always talk to the PI, talk to the doctor, your neurologist, whoever is managing your steroids, to see if they're an alternate option that hey, do they allow this in the study? But most of them are not going to be. Right.
I know the criteria is so strict on those trials, but that's how experiments work. Yeah, thank you. Raj has asked, and I think, he said, does corticosteroids stunt growth in terms of height? And you can go ahead. Yeah.
Yes, we know that, right? So it is part of steroids. Long-term steroids do make those stunt the growth, and that's why we need an endocrinologist in our clinic, and most of my patients are being seen by endocrinologists to see if they have any growth hormone deficiency, if we can replace them with growth hormone to help with that. Maybe do they need testosterone to help with that part? And I think that's, if they have delayed puberty, do they need testosterone? So I think that's important, and it is a known side effect. And again, it's individualized. How much is that bothering you compared to what's your benefit? What are you seeing in terms of benefits from corticosteroids? And again, talk to the endocrinologist, talk to your team, and make the decision. Right.
Thank you. And we're going to jump to our discussion here, but I think there's 2 really great questions left. So we're just going to kind of fire through these. You mentioned this a little earlier, but I want to touch on it again. They're asking, does deflazacort help reduce the risk of cataracts?
So I don't know if I'm not sure if I'm understanding the question. It doesn't help reduce the risk of cataract. If you compare prednisone and deflazacort, the kids who are taking deflazacort are high risk of developing cataracts. So then prednisone. So both can cause cataracts. I mean, steroids, long-term use, they both can cause cataracts. It's just the group who's taking deflazacort are more prone to develop them compared to the group taking prednisone.
Right.
Um,
Thank you. And then there's one more about thoughts on synthetic steroids. They are not approved yet, but do you think it could be a viable answer? This is kind of a nod to the future of corticosteroids, and could it mitigate the side effect issues?
Right. To be honest, I don't know.
Right.
I don't know if that would replace your corticosteroids. I don't know.
Yeah, it's tough. It's not approved, right?
Yeah.
All right, so I'm going to go ahead and jump to our discussion. So I would love to welcome Sheryl and Jake Marrazzo to go ahead and turn on your videos and your audio. There they are. Hey, Sheryl. Hey, Jake. Thank you so much for being here today, for taking time out of your day. It's so useful to get, the real life perspective, right? The real side of the story on the family side as well as the physician. So Sheryl and Jake, let's go ahead and introduce you before we get on to our kind of informal chat about this. I'll let you take the mic, Sheryl.
Well, hello. I'm so glad to see Jake because now that he's at school, I don't get to see him very much. So I'm so happy to see his face on here. Thank you, Dr. Panda. That was great information. I think it's so important to have the science aspect of it, and then to have sort of like, more family experience and things like that. And thanks, Carrie, for having us. I often see steroid as a pretty big topic on Facebook in our groups. And I believe it's sort of a personal decision. But so I live near Boston with my husband, John, and Jake, but Jake is currently at school. I have a lot of obviously personal experience because I'm also a grandmother of a child with Duchenne. I'm a carrier. My daughter's a carrier. My middle son does not have Duchenne. So Jake is currently 19. He was diagnosed at 8. When COVID hit, I kind of had to quit my sales job and stay home. And what that led me to was more advocating and working with CureDuchenne, with our family foundation called For Jake's Sake. So I was kind of bummed when I had to leave my job, but really I was able to do so much more to serve people. And that's really what I want to do. Jake, do you want to introduce yourself?
Yeah, well, hi, everyone. I'm Jake Marrazzo. As my mom just said, I'm 19 years old. I'm a college student living with Duchenne muscular dystrophy. And yeah, it's great to be on here.
Thanks, Jake.
All right. So we're going to start talking sort of about our family history. And when I saw this graphic online, it just cracked me up because really the roids can really cause a lot of issues. We're going to go over sort of our timeline in the next slide, but this was a psychological evaluation from Jake's school 8 months after he started deflazacort. Jake was diagnosed at 8 years old, which is a little bit later. We didn't start steroids immediately, but he progressed pretty quickly after he was diagnosed with falling. And of course, now we knew what we were looking at was Duchenne, which we didn't know what it was before. So Jake had a lot of anxiety to begin with. And this was just sort of like the school would call me often. And so they decided to just sort of do an evaluation. Sort of this is what they said. It was hard for him to not be impulsive. He was disruptive. And you can see, they say he often seeks a great deal of attention in class. I think he was struggling with what was happening with him, his body. And so these were sort of his way to, to get things out. He also was having some issues in reading and math. And one of the things that he struggled with was like starting to be in tasks independently without being prompted and sort of keeping up with everyone. We did make some changes to his IEP based on this, where he would get instruction separately from the whole class. So we found after he was evaluated, we were able to make some changes that would hopefully help him be, more successful. So I think it's important to know that there are strategies available when you have the behavior issues. I don't know, Jake, do you have anything to add to that?
Yeah, I think, because of the steroids and its side effects, it definitely made me struggle on those areas in terms of, maintaining attention and things like that. Socially, I wasn't doing great at that time. Being a kid on steroids and me being, just angry a lot of the time. And I think it was me who said to my mom, I said, I'd rather not walk than have no friends. And I think that I really struggled at that time. And I was thinking, like, I would honestly rather like be accepted socially than, having to be a little less weak.
Right. And you were 12 years old when we had that discussion. So I think it's really important to include the child, the young man, the older man with Duchenne in your discussions, right? Because they're really living the life. We used to do something, Jake, I don't know if you remember, we would hold the angry pillow and you would just punch that pillow to get the anger
get
out.
all that emotion out. I think
that's
that's
worked out really well.
With that sort of thing.
Yeah.
Jake, can I ask a quick question? Sorry to interrupt.
Not a worries.
What was this evaluation and all the behaviors in the class before the steroids were started? Have you ever had some sort of evaluation like that?
I don't recall.
So he did, and in the next slide, we'll sort of go through that. Carrie, if you want to go ahead and go to the next slide, maybe we can start there. So as a mom, I always knew something was wrong. There was something we were missing. He fell a lot. He was very clumsy. He was so anxious. We couldn't have lines in his socks. And I know all the other parents out there are going, yes, no tags in the shirts or things like that, loud noises, what have you. We actually thought he was on the spectrum. He walked on his toes. Asperger kids do that. So we sort of attributed a lot of it to that. And we actually went to Tufts, and Jake was diagnosed with an anxiety disorder. And they never sort of looked at muscular dystrophy as a potential. I have no family history. I didn't know what Duchenne was until they told me that Jake had it. And then when Jake found out what he had and it had a name, he was actually kind of relieved. But so to go back to that, and Carrie, when I was looking for all this information, I went back through like files from like 2010, and I could feel all those feelings again, where, Jake was afraid to be alone. He was afraid if he fell, nobody could help him. Like, he had so much anxiety there before he was diagnosed with Duchenne. My pediatrician actually sent us to a genetic specialist, and she's like, we're missing something. And they were actually testing him for Fragile X. And as you can see, that probably wasn't like what he had, obviously, but so then they tested him for his CK level, which came up high. We went back a couple of days later and it was higher. And so that was when we started to hear about muscular dystrophy. We then started to go to another facility where it wasn't such a multidisciplinary approach. It was sort of like we really just saw the neurologist, and then, oh, by the way, here's cardio, here's pulmonary, and what have you. So we actually started deflazacort, almost a year after Jake was diagnosed with Duchenne, based on my history, because I can't remember all that in my head, but going back through my notes, we saw that, and we actually imported it from the UK because it wasn't approved in this country. And they really pushed us to not try prednisone, just to go straight to the deflazacort based on Jake's anxiety, the potential side effects of weight gain and things like that. And when we first talked about it, I don't know if, Jake, you really remember a lot of this, but we had the discussion. It was kind of like, here's his weight, here's what he should take, place the order, and then sort of that's it. Watch for the weight gain and eat healthy, and which we do anyway. So we were able to do that. And so he was on deflazacort, as you can see, for a few years. And his behavior, like the anxiety, was over the top after he started the deflazacort. And again, we didn't have like a weekend option, or at least they didn't mention that to us. So we just thought this was it, and this was how he was going to be. And we tried therapy, we tried medications, We tried all different kinds of things, and Jake was struggling so much in school. And you heard him say, I'd rather not walk than have no friends. And that was a pretty powerful statement to me. And I think it's so important with this choice of steroids. It's a very personal decision. I can't tell someone how to handle it, because I look at my grandson, Tyler, he's on a pretty heavy dose and he's doing amazing. So it's different with all kids, you know, so I think you have to try many different things to get it right. We did try a lot of different things and we couldn't get it right. And so we made the decision to wean off of it. And we decided if it doesn't work, we can just go back on it, right? So let's wean off of it based on what Jake wanted to do. We talked to our team. Obviously, you can't just stop it, like you mentioned, and we sort of, it took a long time to wean him off of that. But Jake, did you notice a difference after we weaned you off of the deflazacort?
Well, absolutely. Yeah, there was definitely a significant decrease in my anxieties and a lot of like the sort of anger issues that I would have. And, you know, for a while, like I was doing great and I felt like I was, you know, totally fine. And I was like, I don't want to go back on steroids. You know, I think I'm afraid to have those same side effects again, which like, you know, naturally I would be. But you know, towards, I think, yeah, 2018 is when is when we sort of started to discuss maybe it being a good idea to go back on them, because steroids are important to kids with Duchenne. I mean, that, you know, that's the whole point of this webinar, you know, but yeah, I think I really was very adamant about not going back on them. But I was convinced that it was probably for the best to go back on. I was going to go back on a low dose, but I figured that it was probably for the best at that point.
And you did stop walking pretty much right after you stopped taking the steroids. And he was also walking very lordotic, where like his stomach was sticking out. He was on his toes. He fell a lot. So, you know, we knew sort of that was coming eventually, but really when the steroids stopped, it was a pretty abrupt. He stopped walking like 2 months later. And I can remember the day, and it was actually right in the driveway right next to me where that happened. And then we would go to the clinic every 6 months, and they would do obviously cardiac and pulmonary testing, and 3 consecutive visits. So within a year and a half, his pulmonary function just like went down, like, I think it was like 34, 36% in those 3 visits. And so we started to have the discussion about, you know, maybe we should get back on the steroids. You're more mature. We connected with a cognitive behavioral therapist. So maybe we can sort of, you know, get you on a dose that works. And then they started at 12 milligrams, which really for him wasn't a ton. But so the side effects returned, you know, so you could tell he was like weepy and things like that. And it was a pretty quick, like it didn't take long for that to happen. So then Dr. Wong is who we see currently recommended, hey, let's go to 6 and see how that goes. And we did 6. And the next pulmonary.
Was Jake involved in these conversations?
Sorry, I'm sorry, Carrie, I missed you. I talked over you.
No, I'm just saying, like, Jake, how involved were you in these conversations at clinic? Because I think, you know, sometimes it's always people speaking for you. You know, his behavior is like this, but how do you feel? You know, how did you feel at that time? Were you able to say, okay, whoa, we need to pull back on this? Can you walk us through that a little bit?
Yeah, I mean, of course I had a say in, you know, all that stuff. I think, you know,
well, yeah,
I mean, I think I really did realize, like, there was a point where I was just really stressed out and panicky, you know, from what I remember. And I think that was when I was sort of like, no, I think we should maybe wean off of this, because we were trying to, you know, go higher on dosage. But yeah, you know, and I think, you know, and I'm usually involved in all these discussions about, you know, well, you know, what would best fit me and all that.
Right. And you noticed a difference in your lung function, even just with the 6 milligrams. You can see we tried to go up to 9, and even just those 3 milligrams sort of brought some of the behaviors back. So we all decided as a team, including our pulmonary specialist, our neurologist, with Jake, with mom and dad, and we decided, hey, we're getting, the lung function has stabilized, so that's clearly important. And to keep like your upper body going, right? And so we found as a family that 6 milligrams was perfect for us.
Mhm.
The lung function stabilized, and Jake really has, little to no side effects. One of the things I want to mention is sometimes you have a kid with Duchenne, you sort of do too much for them and you sort of let them kind of run the roost a little bit. And my thought was, it's okay that you're angry, but let's not pack, your bags and live there, because you can't really be disrespectful. Like wasn't okay in our house. So, but it's a tough balance, because I really think the anxiety for me and Jake, I think was worse than Duchenne could be. Would you say that, Jake?
Yeah, that I'd agree with. Yeah, I mean, exactly. Yeah.
But what I wanted to go back to a couple of things that people had asked. And when we were talking about urination, one of the things that we found is that when we gave Jake the deflazacort in the evening, he would have issues at night with continence. So we switched to the morning. So that helped with that. And then for starting steroids early, if we had known that Jake had Duchenne before he was 8, I think we would maybe having different discussions, because he would have been on them. And I know that for a fact, because my grandson, Tyler, is 8 and he's doing amazing on steroids. So I think you're right, Dr. Panda, the earlier that you can try it, the better. And it is sort of the standard of care and all that. And then when we're talking about the smaller child, Jake isn't really that small, but we're talking about how it would be better for us to lift him if he was smaller. His center of gravity wouldn't be so high. So if he fell, he wouldn't fall, so there were some good things for that. And as far as weight gain, you can see Jake really doesn't have that, but we also don't drink soda. We are very healthy eaters. We try to stay away from the sugar. And our neurologist has a book that she can flip through and say, hey, here is this and here's that.
Dr. Wong for you.
Yeah, exactly. And you know what? And she's right. And I don't know, Jake, do you anything on that where we did try to be healthy, and you were a part of that I'm not going to drink soda decision and things like that.
Right? No, yeah, there was just a point where I was like, I don't want to drink soda anymore, try and, eat healthier.
Yeah, I'm not sure what he's doing at school now because I can't monitor what he's doing there, but I hope he's eating healthy.
To close out our webinar, I wanted to, and I can take down my screen here because I wanted to ask sort of a two-sided question. Hopefully you guys can still see me. But I wanted to see both from the physician perspective and then from the family perspective. We talked a lot about the push and pull. Like Jake, you even realized, okay, I realized that corticosteroids are good for me. They're good for my lung function. They're good. They prolonged ambulation for a while, and we can't avoid those realities, but we also can't avoid the reality of the side effects. So I'm wondering, so I can start with Dr. Panda. We think about the weight gain, the bone fragility, and the behavior. And of course, I think the growth hormone too is a big conversation because that's a really tough side effect as well, especially for a young man. I'm wondering, on your side of things, what are some mitigation, tactics or medications that have been introduced into the standard of care to help combat these side effects? And then Sheryl, if you could just reiterate on your side, I loved how you talked about cognitive behavioral therapy, and then also about that kind of list of we weaned, we went up, we went down, we had a conversation. So I'll start with Dr. Panda, and then we can move to Sheryl to close this out, giving people tangible tips to go home with today.
Sure, I think it kind of the adverse effects that you're going to see, it's like I said before, short term and long term, right? When you start, the main two things that you worry about is your behaviors and the weight gain. So the two main things at the time you start. So the behaviors, it's not just about the kid, the whole family. They need to understand what's going on, and we have I usually don't go straight to medications. There are medicines that can help with anxiety. There are medicines that can help with depression and stuff. But I think our psychology evaluation, CBT, and then also family therapy and helping family to how to cope up with these. I think that's important from that perspective. And in terms of weight gain, nutrition, again, that also talks. So it's not just about, for example, Jake. It's the whole family. The whole family needs to change for Jake to follow. If you're eating ice cream or pizza and telling Jake or son, not, hey, you can't do that, it's not going to work. And that nutrition is key for the weight gain part. Then as time goes on, when you're taking long, again, just to go back to the behavioral issues, they do get better. It's just that short period. So I reiterate that to the families, they do get better with the support that they get. And as the brain matures, as they mature as a person, they do get better. Then in terms of, as the time goes on, of course, the bone, your osteoporosis and stuff, we have bisphosphonates, which are medications that you could use to mitigate that part. What else? And then, of course, for growth, like I said, delayed puberty, they can have delayed puberty, so that we can use testosterone, and then growth hormones if someone has growth hormone deficiency. So that's, again, it comes back to the importance of multidisciplinary involvement and other specialists who can. In the past, it's all neurologists who did everything, right? Many years ago, now we have providers who can follow these things: bone health, nutrition, endocrine. I think it's key to get them all involved. Sorry, I'm taking too much time. Go ahead, Sheryl.
You're not. No, go ahead.
No,
Sheryl,
that's
please.
awesome.
Sheryl and Jake.
So we didn't do growth hormones. Jake does take a Fosamax, and actually he has to get his wisdom teeth taken out as soon as he gets out of college. And they kind of want him to continue to take the Fosamax during that. So when Jake had anxiety, and he pulled his eyelashes out, it was a pretty rough time. And we started trying meds, and meds are really challenging because there's so many different side effects with those that are mental. And so when you try meds, you sort of have to, it's hit or miss, and you have to keep trying different types. And at one time, Jake was on 3 different anxiety medications, 3 of them.
It's trial and error.
Yep. And then seeing a therapist. And really, the cognitive behavioral therapy is a game changer, right, Jake? I mean, wouldn't you say that? Since
I absolutely would recommend that to anyone who's not just with Duchenne, but anyone who's feeling really anxious in general, because CBT more focuses on, giving you tools, tangible things, that could actually help reduce anxiety, or at least help you get around it. Because anxiety, we're diagnosed with it, it's never going to go away, but I think it's a process of, sort of getting around it. So, yeah. And if I were to have to go on a higher dose of steroids, I think now, because of how much I've matured, I think, I think if that were an option, I would consider that if it worked, and if not, then, it's just a process of trial and error. You have to figure out what works for you, and, just side effects and such. If they get, worse, then I think quality of life is the most important thing,
Well, you led me right to that. That's what I was going to kind of close out with, Jake. I was just going to ask, this journey obviously has been long for you, and there's been a lot of changes, and it isn't easy. And I think that a lot of families are going through the same things. And I just wanted you to kind of tell them about your quality of life. Maybe I know you're having a great day, you said today. So maybe you could just let people know a little bit of hope on the other end of steroids if they're currently struggling with those decisions.
Yeah, well, I think growth, I think that's one of the most important things to take into consideration. If you're feeling like the side effects were once really bad, and you're like, okay, no, we need to wean off of this. But then maybe years later, you're like, okay, maybe I can handle this now. And maybe if I go up a few milligrams, then it'll be okay. The side effects will be lessened now that, I've grown. And that's what Dr. Wong's always said to me, is the maturity level I mean, it just increases with all of us as we get older. You know, we learn new things and about life, and you know, as we get older, I think that is, yeah, I don't know, kind of lost my train of thought at the end there, but
No,
But it gets
you're-
better, right? And
you're
look
good.
at
It
you.
but
gets
it definitely
better.
does. Anxiety. I mean, yeah, I've come so far, you know,
Oh, yes.
from where I used to be. Because like now I'm in college, and you know, doing awesome things, meeting great people. So
Well, I'm happy.
I'm
for you,
really
Jake,
happy
and-
with where
yeah.
I'm at right now.
Yeah. I think that hopefully inspires a lot of the families on the line that are going through this. You know, they can look at you and look at your journey and say, you know what,
Yeah.
I know we might have to make some tweaks along the way, but this could be worth it for our quality
Yeah.
of life, and always
You know,
get in
and
touch with your clinic, right?
And I think whether we like it or not, like I think life, a lot of it is just a game of waiting. And you know, to any parents or younger, you know, kids with Duchenne watching this, just remember that like things will take time. And then I think maturity does take a while, but I think the wait is worth it. Because again, like you know, like we may not like it, but a lot of life is really just waiting for things to happen. But I think, you know, I feel like life happens like exactly the way that it's supposed to, and there's some sort of plan that's just being developed. And you know, I would just you know, like let everything fall into place as they may.
Right. Thanks, Jake. Thank you, Sheryl. Thank you, Dr. Panda. I think this was a wonderful, both informative, but also, you know, uplifting, and you teach us a lot, Jake, and thanks for being here today, everybody.
Of course.
Just to close it out, please, if you have questions, cares@CureDuchenne.org. It's me on the other end, and usually Sheryl, so reach out to us. But I'm so appreciative of those attendees today, and especially of the speakers. Thank you.